And we are back with Brunch, a taste of Tobago. And like I said before I went to the break, we get to speak with so many wonderful people, so many souls and energies that grace our presence on the Brunch set. And of course, my first guest is no different. She is a staple of the Brunch community, as a matter of fact. Billie Sterling Lewis joins us, and we have had so many wonderful conversations with my sister dealing with mental health and mental health issues. And today we are going to be touching on diagnosis of mental health, and she is the right person to embark on this type of conversation with. So let me say good morning to Sister Billie. Good morning to you.
Good morning, my sister. How are you?
I am blessed. I am not even gonna complain. I woke up this morning and that's a big deal. That means I have
Yeah, it
something
is.
that I need to do, which is why my life was spared by the Almighty. So I am gonna be blessed. I'm gonna stay in that positivity and just go forth and go through the day and make my life, do something positive with my life on my journey. That's where I'm at. How are you doing?
Oh boy, I could echo your sentiments.
Oh
It's a
yes.
wonderful opportunity to be alive, and I say that without it being a cliche, but also so wonderful to be here to share one of my passions, which is mental health,
Yes,
and living and thriving no matter what we go through.
definitely. And more and more persons are receiving mental health diagnosis. What exactly does that mean? What is a diagnosis? Because I know there's so many people, we take it for granted that we know basic terminology and basic concepts when it comes to mental health. But there are some of us who are very oblivious to what this entails. So let's touch on what exactly is a mental health diagnosis. Let's start there.
Yes, no, that's a good place to start. When we talk about mental health diagnosis, there are three words that we often hear people use. We would hear diagnosis, we would hear diagnose, we would hear diagnostic. And this is used in most medical settings in the mental health setting. And it could be a verb. So when we diagnose, we are using a set standard principles, tools, techniques to address to look at a situation with a person. We call them symptoms, what they may be experiencing, how long they may be experiencing, what impact it's having on their life. And that assessment of those informations will allow you to make now a diagnosis with which is now a description or a terminology of what all of these symptoms collectively come together to form. So for us in mental health in this part of the world, we primarily adhere to what is called the DSM-5. It's in its fifth edition. That's a Diagnostic Statistical Manual, and that's led by the American Psychiatric Association. And within that classification, we have hundreds of symptoms that collectively come together to form a diagnosis, right? And we have diagnostic tools. So there are things that we would use to help us make the diagnosis. So it can be tricky sometimes, but in and of itself is what people are experiencing and what terminology we use to describe the collection of the symptoms that they're having.
That's so well. And recently I have been experiencing, just little tweets and messages and notifications where young children are going to their parents and saying, well, mommy, I feel like I'm depressed, or daddy, I feel a bit heavy. I don't know what to do. And sometimes the response of the parent, it's positive and sometimes it's not. I have heard parents saying, what are you depressed about? What do you have to be depressed about? You are so happy. You don't even know where, these challenges taking place, and then the conversation just falls off or it's swept under the carpet. And there's a change coming, but I don't know if if it's changing rapidly enough with regards to having that type of conversation. What are some of the distinctions between a childhood diagnosis and an adult diagnosis?
Yeah, thanks for that. I mean, even what you were saying before I answer that question, I really want to latch on to that aspect of parents becoming more sensitive to their children's declarations. Now, I am very big on this. I've been in the field over 15 years, and I am not one who likes diagnosis in the way that many people use it. But when a child begins to explain to you, mommy, daddy, auntie, grandma, uncle, I'm having these experiences, it should be enough for you to stop and ask, even if it's just three more questions. In other words, pay attention, zone in, and then see what help you can get for the child. Now, what we find happening is that we have childhood disorders, which are disorders that tend to show up in a child's life from early infancy into, up to 18 years old. And then 17, sorry. And then from 18, we would have more adult diagnosis taking place. The differences are most of the childhood disorders are developmental disorders. Now, some of it could be neurological. We could have behavioral. We could have affective disorders as well, which would be how they feel. So you talked about the child saying, "I'm feeling depressed" or whatever. So the child would be experiencing these things. It could be, like I said, observed conduct, I said disorder, but observed conduct issues or mood issues. Sometimes there's trauma. And that is also something that's diagnosed. The thing to understand is that many disorders can be diagnosed both in adulthood and also in childhood. And another important point to understand is that because a lot of children do not receive diagnosis in their childhood years, a lot of issues remain under the radar until they reach adulthood, and it's normally young adulthood, and then we see them receiving diagnoses because the situations have not been dealt with and they begin to disrupt their lives. Schizophrenia is one of, or other psychotic disorders, depression, those tend to fall into that, and some learning disorders too, like ADHD and dyslexia. So in both childhood and adulthood, we can see diagnoses taking place. The tools are different. The methodologies differ, but we can have diagnosis happening in childhood and adulthood. And may I just add this as well, even in older adulthood, we tend to see a lot of neurological issues coming into play, which can now spiral into other issues like mood disorders. So we can have diagnoses taking place in older adults as well. I hope that kind of helped because it's a whole big
Yeah, it's
basket.
wide. It's wide. But it did help
Yes.
because deterioration is almost imminent. It always seems to happen. And how do we pinpoint? Because I found that so many of us are walking around with, as you said, childhood trauma. And it is so immense that it completely takes over the type of adults we turn into, the choices we make, our methodology, our reasoning, what we see as right and wrong, and these are basic, but it takes over when this conversation is not dealt with, when we don't, delve in to childhood trauma. And, what tends to lead to deterioration of a person's health? What are some of the factors that tends to lead or lend aid to that?
Well, you started mentioning a major factor, and that is trauma. And not only childhood trauma, but trauma at any stage in a person's life. And I always like to make this distinction. Trauma is not necessarily an event. Most of the events in our lives are neutral. Trauma becomes trauma based on the way the person interprets the event. All right. And so a lot of children are going through instances of abuse and neglect, poverty. These are all factors that affect not only children, but also adults. And these are some of the things that we have found tend to lead to a breakdown or a deterioration of a person's mental health. Many times, losses. And I'm not talking just about death losses. We're talking about losses in terms of non-death, loss of a relationship, loss of an opportunity, loss of a dream, loss of health, loss of a limb. These are things that also, because of how the person interprets them, and sometimes they don't have the support that is necessary, can become, can fester, I like to use that word, and become mental health issues for them. And illness is one that is often overlooked, but persons who experience terminal diagnosis, again, the word comes up because it's also using the medical term, or living with a chronic condition, often do experience a deterioration of their mental health, especially in the issue of area of mood. So many persons who have a terminal diagnosis or chronic illness, like for instance, fibromyalgia is a major pain issue that a lot of people are dealing with, especially women. And many times these women with this pain disorder actually end up having depression, developing depression and becoming suicidal because the pain is so intense. So these are a number of factors. Living in a crime neighborhood, having domestic violence in your home. These are some of the factors that could lead to the breakdown of a person's mental health.
Have so much more to talk about, but we're going to take a break and we're going to be right back with more Brunch, a Taste of Tobago. My sister Billie Sterling Lewis is going to be rejoining us, and we're going to speak just a bit more on diagnosis of mental health issues. We're going to take a break. We're going to be right back. Stay tuned. And we are back with Brunch, a Taste of Tobago, and such a wonderful conversation we have embarked on. Billie Sterling Lewis joins us again for this wonderful conversation that absolutely needs to happen. The narrative needs to absolutely develop a sense of change when surrounding mental health and mental health issues. Dr. Billie, are you there?
I am
Yes.
here. I am here.
Yes.
I
So
receive
notice I
my
said
prophetic
doctor.
thank you. Yes, I receive it. It's
So
about time. I've
receive
had so
it.
many. Yes.
But one of the things that has always been a buzz, with the whole diagnosis narrative, you know, there are so many persons that have common issues. There are issues that would come before you that are so common to so many persons. And you diagnose, and then there's an underlying factor that you probably didn't see when you started the preparation and started the process. And it lends to another conversation that needs to happen. And so we're chipping away at so many layers because, like you said, trauma, it does not have to be an event. It could be any type of physicality, any type of memory, any type of, catalyst that would bring about a certain type of behavior or certain mode of behavior. What common diagnosis would you say exists in our population?
Yeah, for in our region, Trinidad and Tobago, and for the Caribbean, statistics have also put Latin America with this. What we tend to see are mood disorders, anxiety disorders, and psychotic disorders. I said and, but let me put a comma there. Psychotic disorders, and one that tends to what we call become morbid or coexisting with these is substance use disorder. Now, with all of these things, we tend to have a high prevalence of suicide. So it is not necessarily a disorder in of itself, but it's often ranked with these disorders. So in the region, in especially TNT, we have high levels of mood disorders. Mood disorders is anything that leads to changing the way a person feels and how that feeling affects their life. So that is depression, unipolar or bipolar depression. That is also, well, it's normally those two. And then we have anxiety disorder. So we have anxiety disorder, we have panic disorder, we have persons who just have panic attacks, we have phobias, all of those fall into it. And then, like I said, we have the psychotic disorders. In our region, we primarily see schizophrenia or anything in the schizo category. So schizotypal, schizophrenia, those sort of things. And then substance use. This is important because over the years, we have found that most of our psychotic disorders were what we call substance induced, which means that persons experience a psychotic break because of the substance misuse, a really negative effect of the drug that they took. And while in many instances the substances may lead to, in many instances, they're also exacerbating or making worse a pre-existing mental health condition. So these are what we generally see in our region, and also, like I mentioned, suicide. Now, we may say, well, we don't hear so much about suicide. The thing about suicide is that we have many attempts. Our hospitals can attest to that. Our mental health unit can attest to that. Persons like myself who work in the field privately can attest to that. So we have many attempts of suicide. We don't have as many completions, but we have a lot of attempts. And it is something that is requiring a lot of attention from our healthcare system and our mental health system. So these are what we primarily see in our settings.
Discrimination regarding mental health issues. How does discrimination impact our individuals and by extension our communities? I know this is
Yeah.
vast, but a synop
Yeah.
of any type would be wonderful, because I feel that we need to touch on that just a bit. So how does discrimination impact our communities?
Sure. Well, discrimination comes from stigma, and stigma is a mindset, a particular mindset towards something. So you stigmatize mental illness, meaning you have a negative mindset about mental illness, and that leads to a behavior of discrimination, which means that we treat the person who we know for a fact or presume to have a mental illness in a negative way. It follows from the stigma. The problem with that is because of the high levels of stigma in our culture, a lot of people are experiencing mental health conditions and do not come forward for help. I'm very passionate about this because a lot of our young people are dying. A lot of our young people are turning to self-medication through drugs and alcohol because they're afraid to say, I'm hearing voices, or I feel sad and low a lot of times. My self-care is affected. I don't know why I don't want to bathe my skin. I don't know why I don't want to brush my teeth. These are real issues. But the stigma of society says to them, well, something is wrong with you and you don't belong here. And that causes them to stay quiet. And the discrimination comes now whenever, like I said, they know. Many persons, for instance, will be teased and mocked because of their mental illness. There's some employers who would discriminate against an employee when they find out they have a mental illness. I've had clients ask me many times, do I need to tell my employer that I have a diagnosis? And I often say to them, based on where they are, once we have stabilized them, they generally do not have to know. People may question me on this, but we understand the implications of that. If your mental disorder is controlled through therapy, through medication, through lifestyle approaches, and it does not interfere with your work, you do not necessarily have to have your HR department know about it. Maybe you may have a supervisor that you trust, and I say that again, that you trust, who's not going to use it against you if you have a mess up. But definitely, we don't want people discriminating. People in relationships, a lot of intimate partner violence is predicated on the fact that the partner knows the person has a mental condition. They may be depressed. They may say, well, we know your mother crazy. And so it affects how they treat the partner. So stigma and discrimination is real, and we want to address it because it affects the lifespan and the ability to have good quality life of the person living with that disorder.
Is diagnosed, what
Say that again,
should,
I missed part of it.
are you hearing me?
Yes.
Right. When a person is diagnosed, what should the next step be? Just for the persons watching who are battling constantly, what should the next step be when you are diagnosed, when you receive a diagnosis of any kind with regards to mental health?
Good. That's a good question. Can I just preface it by saying who should diagnose? Your sister, your auntie, your mommy should not be diagnosing you, even your pastor,
Be.
unless they're a professional. So we want to make sure doctors or mental health professionals or psychiatrists or psychologists, clinical mental health professionals are doing the diagnosis. But what's next? That's a really good question because that's where people get stuck. One of the first things we want to do is encourage people to get support even before we move into treatment, because sometimes people delay treatment because they're going through that those stages that Kubler-Ross spoke about. They're going through shock and denial, and in that time it's important for that person to get support. Maybe you may not be able to get support from a family member or friend. At that initial stage, it may be from your healthcare provider. Speak to them, let them know, hey, I just received this. I'm scared. I don't know what it means. Because the next thing is people respond differently to a mental health diagnosis. Some people are relieved that they find out what's going on with them. Some people feel ashamed. Some people are scared. Some people feel that they're failing God, they're not saved enough. And so there are different responses. Whatever the feeling and the responses, get support. Once you've gotten that support, it is important that you move into informing yourself about what this diagnosis means for you. Please note that your diagnosis does not define you. So that's why I'm very big on not using diagnosis. When we use that word, I am, that is an affirmation. And whatever we put after I am will determine where your life goes. So I don't like people to say I am depressed or I am bipolar. You are not that. You are living with something or you are experiencing something right now. So become informed and understand that this does not define you. It doesn't change your character. It doesn't change your identity. It doesn't change your divine purpose. And from there, allow yourself to move into finding a trusted family or friend that you could share this with, who could help you navigate this time, and then definitely get treatment. Treatment may differ for persons. We generally may have persons starting out with psychotherapy. You may have to be put on medication. And I want to say this, especially for people who are faith, having to take psychiatric medications or antipsychotic medication does not mean that you're not saved. It doesn't mean that you're not serving God or praying enough. Things happen. And we have talked about this lots of times. The Bible is replete with examples of people who experience mental health conditions. And so the shame keeps people from accepting the medication. A lot of people say, I think it's going to make me addicted to it. There's some medications that give you negative side effects. Vomiting, nausea, lethargy. Sometimes some of them may be habit forming. Opioids can be like that. Some benzos may be like that. But it is important in the initial stage of support with a medical practitioner, that you keep a communication line open with your practitioner. Maybe the public health system may be overwhelmed because we know that's how all public health systems are. Find a private practitioner. You can't go every week. That's fine. Go once a month. Explain to them, they put me on this medication. When I take it, I find I have suicidal thoughts. You need to let them know. They can change it. They can lower the dose. So we want to have support happening. We want to have the person informing themselves, educating themselves about this disorder. We want to ensure the person is also bringing along a support system in terms of educating a family member or friend, and then ensuring that they get treatment. And not only get treatment, but be compliant. Lots of people are prescribed approaches and medication for their mental health issues, and they do not comply. And their conditions worsen. When most times a 60-day regimen or 90-day regimen of antidepressants will stabilize them and cause them to get to a place where they don't need it after 6 months. But if you don't take those initial steps to be compliant with your treatment, it can affect what can happen to you going forward.
And Dr.
All right, so
Billie,
that's
let
what
me just interject. Let me just interject because we have so much that you need to say, but unfortunately we are out of time. So you definitely need to come back and we are going to finish this discussion. I promise you we're going to have you back and we're going to finish this discussion. But we touched on so many issues that I know persons wanted answers to. And for that, I thank you. So from us to you, blessings and peace and love. and also
Thank
success
you.
in whatever you endeavor to do. Thank you so much, guys, for viewing. I was speaking with Billie Sterling Lewis, and we were talking about mental health and diagnosis of mental health in adults and, of course, children. We're going to take a break. We're going to be right back with more Brunch, a Taste of Tobago. But before we go, our trivia question for today. This popular tourist attraction is a staple of Tobago's vibrant nightlife. The answer, of course, at the end of the show. We're going to be right back with more Brunch, a Taste of Tobago. Veteran Calypsonians take the stage, or take the brunch set, and we're going to be right back with more. Stay tuned.